Hello, I'm Kathleen Digre, and I'm a distinguished professor of neurology and a professor of ophthalmology in the Department of Neurology at the University of Utah. I'm also at the John Moran Eye Center. And we are recording this for many of you who cannot join us today since you may live far away. But I'm going to be talking about when pressure gives you a headache. In particular, we're going to focus in on idiopathic intracranial hypertension. Headache is so common, and migraine is the most bothersome headache, but everyone worries about, could it be something else? Could it be pressure in my head that's causing this headache? And would increased pressure in my head cause a headache itself? So I'm going to start with a case. This is Sharon. She's 34. She was sent to us for headache. She has had recent weight gain and has been very healthy, except that she's had migraine in the past. And she reports that she has transient dim outs of vision, a whooshing noise in her head, something like whoosh, whoosh. Her headaches are much more severe now than her normal headaches, and she wonders what is going on. So she comes to the clinic, and this happens to be in our neuro-ophthalmology clinic, but neurologists can also check things out as well. And we check her vision, and she's 20/20. We check her visual fields to confrontation, and I'll show you what a visual field looks like in Sharon. And then the most important thing is that we look in the back of the eye, and I've got this schematic of an eye, and you can see I look through the cornea, I look through the pupil, that's the hole in the middle of the iris, the colored part of our eye. And what I'm looking at is the optic nerve. And that optic nerve that you can see on the right side here is normal. And that's what it should look like. It should be normal. But when we go to Sharon, we see that she has these swollen optic nerves. Now, we look for swelling by looking to see that it's raised around the entire disc. Even the blood vessels are sort of draped over the disc. There might be some hemorrhaging, just some blood that's leaked out, and the vessels are tortuous, and this is what we call papilledema. Remember, it should look like that. And a normal disc should look like this, but hers looks like that. So she's got papilledema. And that tells us that the pressure is raised in her head. It's a sign of intracranial hypertension. We check her formal visual fields, and she's got, these are big blind spots, and she's got some visual changes in her visual field. So we're worried in Sharon about visual loss. Then what we have to do is we have to do a MRI scan. And here we're looking at several things. First, I look for signs of pressure where it's pressing on the back of the globe. So you can see I've got this arrow pointing to where the optic nerve is going into the eyeball. And you can see it's flattened on both sides. In fact, you can kind of see how it protrudes into the globe. Then I look on the sagittal view, and I can see what we call an empty cella. Normally, the pituitary gland fills this entire spot, and her pituitary gland is pushed up against the side from high pressure. Then we do a lumbar puncture, and this is to tell us whether the pressure is elevated. And her pressure was 350 millimeters of CSF, and normal pressure is between less than 200 to 250 millimeters of CSF. So her pressure is abnormal. It's elevated. The fluid, when we test it, is normal. The protein in the fluid is normal. The glucose in the fluid is normal, and she has no white cells, which tells us this isn't due to meningitis or something else. And So she's got what we've come to know as idiopathic intracranial hypertension. It used to be called benign intracranial hypertension, but it is not a benign disorder. And so it's lost this name, benign intracranial hypertension. Idiopathic intracranial hypertension just means this is primary intracranial hypertension. But there are syndromes that look just exactly like this. We call them pseudotumor cerebri syndrome. So it looks like a tumor in the brain, but you go and do an imaging and there's no tumor there. And so there are basically kind of two flavors of pseudotumor cerebri syndrome. One is the idiopathic form, which is we're talking about tonight. Idiopathic means it's primary intracranial hypertension. And then there's the secondary form. And the secondary forms, the most common one is venous sinus thrombosis or obstruction. And so frequently we have to look at the veins in the person's head to see if the veins have clotted off, because this can look identical to idiopathic intracranial hypertension. And then there are medical disorders that can also raise intracranial pressure, like Addison's disease. This is a disease of the adrenal gland. Hypoparathyroidism. This is a disease of the parathyroid gland, which lives in our thyroid gland. Chronic obstructive pulmonary disease can create high pressure, as can right heart failure, sleep apnea, iron deficiency anemia, and even, as I said, meningitis can look like it's intracranial hypertension with papilledema, raised pressure, but the spinal fluid is abnormal. Medications have also been known to increase intracranial pressure. The most common one in adolescents is tetracycline, minocycline, because it's given for acne, but also growth hormone, vitamin A, lithium, Norplant, other types of hormonal manipulations can also be involved. Less likely, sildenafil, amiodarone, and other drugs can also be associated with raised intracranial hypertension. Now, idiopathic intracranial hypertension is not common in the general public. So it's only 1 per 100,000 people. So let's say it's a city of 1 million, you might only see 10 people. But if you're obese, then it is 10 to 20 per 100,000, and that means it's as common as multiple sclerosis. And we all hear about multiple sclerosis. It's definitely more frequent in women, 4.3 to 8 to 1, meaning that women are almost 8 times more likely to have this disorder than men. And when we did a big trial called the Idiopathic Intracranial Hypertension Treatment Trial, IIHTT, we found that almost everybody was a woman who was entered into that trial. The age range is usually 14 to 60. It can be older in men. And in children, let's say less than 16, the boys and girls are about equal. There may be a genetic aspect to this disease since it's been reported in several families. And we found that there was a genetic incidence about 5% in the idiopathic intracranial hypertension treatment trial, but we were unable to find a gene. Now, I want to go over the symptoms of increased pressure because that's what people worry about. And the number one symptom is headache. And in the idiopathic intracranial hypertension treatment trial, almost 85% of the people who were in the trial had headache. The next most common symptom was transient visual obscuration. That means just a dimming of the vision. It's kind of like you stand up quickly and your vision dims out. Back pain was also common, along with neck pain, dizziness, light sensitivity, that whooshing noise I talked about that our patient had, Sharon had, visual loss in 1/3 of the patients by visual fields, cognitive changes, meaning they feel like they're fuzzy in their head. About 20% had double vision, and some people had pain going from their neck into their arms or down their legs. And so these were the symptoms that we found in intracranial hypertension. Now, the problems that people who have this disease have, one is visual loss. Now, Sharon, she was 20/20, but her visual field was very abnormal. And that's why we follow patients very carefully who have papilledema, because we have to be sure they don't lose vision. Secondly, we know the quality of life and the visual quality of life is reduced in this disorder. This really interferes with people's lives. Then people get foggy thinking. Their thinking becomes somewhat muddled and confused. Also, most of these people have obesity. And as we know, if you're overweight or obese, you're more likely to have diabetes, metabolic syndrome, and women can get into polycystic ovarian disease. And the most common thing that is a problem for patients with IIH is headache. So we talked about the symptom of headache. We talked about pain in the neck and shoulder blades. Sometimes people get pain with eye movements. What's interesting is how bad the headache is doesn't correlate with the pressure. So you can have somebody with really high pressure and very little headache, or you can have somebody with kind of borderline elevated pressure and the headache can be terrible. So really the headache does not correlate with the pressure. But headache is the most difficult part of our treatment. So most people who were in that idiopathic intracranial hypertension treatment trial reported their headaches were 6 out of 10. 10 being terrible, 6 was still pretty bad. And 5% said 10 out of 10. And over half said it was constant daily. And we did a measurement called a HIT score. It's a daily score. It takes into consideration what your headache has been doing over the last few days and month. And the HIT score was 60, which is markedly elevated. And also what was interesting is that 41% of people reported they had migraine before they had the intracranial hypertension discovered. And in the normal population, no more than 17% of patients, usually women, have migraine, 10% of men. So this means that these people have more migraine than anybody else. They've got a lot of migraine. And we found that that even if you get the papilledema gone, that swelling behind the eyes, the headache can be chronic in almost half of our people. We do know that it's a better outcome if you're young, if the pressure is really high, and we get quick control of the intracranial pressure. We also learned that the phenotype, that means what does that headache sound like when you kind of listen to what is going on with the headache? It sounds like migraine. 52% in that study had migraine and 16% had probable migraine. That means that, almost 70% of people had what sounded like migraine. And the rest had kind of tension type or probable tension type. And about half the individuals in that study were overusing medication because they had such bad headaches. We did find, as the HIT-6, this terrible score that they had increased, the quality of life decreased. So the headache was directly related to the quality of life. We did find that the headache disability did not correlate with how high the pressure was. Or it didn't didn't quantify and correlate with how much obesity they had, how much weight loss they had, what their papilledema grade was or what their visual field was. And then we compared those people who had pressure, high pressure, because they all have this diagnosis. Those people who had headache, but those people who didn't have headache, remember that there were about 16% that did not have headache, and they could find no difference in the rate of pressure. So the headache didn't correlate with that pressure. Now, you might ask the question, can there be increased pressure without papilledema? So here on your right is a disc that is swollen, and on the left is the disc that is not swollen. Actually, this is in the same person. This is a person that we had seen who had increased intracranial pressure, but had only swelling of one disc. So not everybody gets papilledema with increased pressure. For example, people with brain tumors who have raised intracranial pressure don't always get papilledema. And when we measure and look behind the eyes when somebody's had head trauma with very high pressures in the head measured by bolts in the intensive care unit, papilledema took days, if at all, to occur. And this asymmetric papilledema can also occur. So are there legitimate reasons that you would not get papilledema or swelling of the disc with increased intracranial pressure? Well, let's say the papilledema is really mild and it's really hard to see. And that, number one, means that it has to be looked at by a competent person who's used to looking in the back of the eye to detect papilledema. There is a tool called optical coherence tomography that ophthalmologists use when they're looking in the back of the eye to see if the disc is raised. And that sometimes is very helpful. Early in the course, if it's very early in the course, a patient hasn't had time to develop papilledema, they may have no papilledema. Or if it's very, very late, the papilledema has gone away, that may be another reason we don't see it. The other reason is maybe the disc has become gliotic or there's fibrous tissue on it, so it can't swell. And sometimes, on this little diagram to the right, the spinal fluid has to track along the optic nerve from inside the brain to the optic disc. And for some people, there's not enough room for that fluid to get to the disc to push on the back of the eye to give swelling. So there are legitimate reasons why somebody might not have papilledema. We did compare patients who had idiopathic intracranial hypertension without papilledema with those with papilledema, and but it only occurred in about 6% of our patients. We age matched them. They were all examined by a neuro-ophthalmologist. We found the symptoms were very similar. The headache characteristics were also similar. Visual function was better without papilledema. The opening pressures were taken many more times. Those people had 12 more than one LP performed to determine how high the pressure was. But we did find that the pressure with papilledema was much higher, up into the 500 range. So you can see that it's very similar, but it's not very common to have it without papilledema. Now, you can make the diagnosis without papilledema in the absence of IIH, idiopathic intracranial hypertension, in the absence of papilledema, if you have a normal neuroexam, the imaging is negative for the mass or hydrocephalus or other causes of high pressure, the spinal fluid is normal, the opening pressure is elevated, and in the absence of papilledema, you have to look for those signs like the empty cella that I showed you before up at the top, the flattened globe like I showed you before in that second picture down below where the arrow is pointing to the back of the eye, and distension of the nerve sheath. That's where the spinal fluid is tracking on the nerve from the brain. And then stenosis of the transverse venous sinus. And we found that if it was stenotic, along with these other findings. And if you had 3 out of the 4 findings, it was about 100% specific for the diagnosis, but only 64% sensitive. That means that if you have those 3 out of 4, it's pretty specific for raised intracranial pressure. So that's why we do imaging studies and why we have to correlate the symptoms. We have to correlate what the nerve looks like. We have to look at the imaging. We have to look at the spinal fluid. That's why making this diagnosis is really important and should be done by people who know how to do it. So increased pressure without papilledema is rare. It can be diagnosed by a specialist, but we want to be careful to not overdiagnose. And when there's no papilledema, we don't worry about visual loss because usually these people do not lose vision. We treat this more like migraine and treat the headache itself. And we don't worry so much about the pressure. So let's talk now about the treatment of intracranial pressure headache. So the first thing we always say is if the person is overweight or obese, losing weight definitely helps. In fact, if you lose only 5% of your weight, 10% of your weight, it can reduce the headache and help reduce the pressure. And that's also helpful in chronic migraine. There are some new weight loss drugs that are coming out that may be helpful. You have to stay tuned for that. There are medications that lower the pressure, and those things are usually acetazolamide or other carbonic anhydrase inhibitors. And what they do is they reduce the amount of spinal fluid being made. Other diuretics also can be helpful. The best treatment is basically a diuretic like acetazolamide plus a migraine preventative. Doing frequent lumbar punctures is not worth the pain because there's very little gain. And then we watch for medications that increase weight because we don't want that. And of course, we want to watch for medication overuse. Now, here I also said that the medical treatment for high pressure is acetazolamide, but there are other medications that have been shown to be helpful. Methazolamide, furosemide, chlorthalidone. And then the medications that we use to treat the headache are very similar to what we use in treating migraine. Propranolol can be used. Topiramate also can lower intracranial pressure. So many people who've got little tiny bit of papilledema, but more headache, we really use topiramate because it causes weight loss, it deals with the headache, and it can lower the pressure. Other medications are like tricyclics, like amitriptyline, nortriptyline, valproate, nonsteroidal anti-inflammatories sometimes are useful, like ibuprofen or naproxen, verapamil on occasion. The calcitonin gene-related peptide monoclonal antibodies have been reported to be helpful in this disorder for the headache. And onabotulinum toxin has also been helpful for treating the headache associated with high pressure. Now, you may be interested in getting more information, and I'm going to tell you about some resources. This book that I'm showing you, Idiopathic Intracranial Hypertension Explained, is a whole book. It's a guide for patients and families with idiopathic intracranial hypertension. I'm also going to show you the novel website, but there are other organizations that have information on this disorder. This is the novel website. This is novel.utah.edu. It's a partnership between the North American Neuro-Ophthalmology Society and the University of Utah Eccles Library. And that we've built a library, a virtual library, and in this library, there's a patient portal. And you just go to the patient portal, and you can find many, many, many diseases. But the disease you may want to get some more information about is going to be pseudotumor cerebri or idiopathic intracranial hypertension. And there we've got patient information brochures, materials from our library collection, Medline Plus, which is with NIH, support group information, and other tools to live a healthy life. This is the patient information sheet that you can download for free and make a copy of and read further about the condition. And on the Moran Core website, morancore.utah.edu, which is a partnership between the Moran Eye Center and the University of Utah Eccles Library, we built a resource and education. And once a year, I do a presentation on idiopathic intracranial hypertension. And the last one I did was 2021. But the next 1 hour lecture with all the new treatments, and we go through pathophysiology, we go through a much deeper discussion about idiopathic intracranial hypertension, will be November 1st, 2003 at 6 p.m. at the Moran Eye Center. It'll also be posted online. So if you missed the time or you couldn't attend, you can still visit morancore.utah.edu. And after I do the presentation, November 1st, it will be posted to the Moran Eye Center website, and you can watch it there for free. Let us know if you'd like to come. We're doing it in person, where you can meet other people who have raised intracranial pressure, and we'll be discussing headaches further.